Hello, welcome to this presentation. My name is Santosh Abraham. I'm working as a specialty registrar in Scarborough General Hospital, New York. So this presentation is mainly for candidates who are planning to take the specialty certificate exam in endocrinology and diabetes. So I'll start with phaeochromocytoma, because this is one of the several topics in the series of adrenal related issues which I'm going to present in the next few days. So phaeochromocytoma is one of the most important topics in the SE exam, which is frequently tested. So I'll just go with the definition. So the definition is you have adrenomedullary chromaffin cells and they secrete epinephrine, norepinephrine and dopamine. So phaeochromocytoma is basically a tumor of these cells. And you have phaeochromocytoma when it is adrenal, and you call the same tumor when outside the adrenals as a paraganglioma. So that's extra-adrenal. So it could be from the thorax, abdomen and pelvis. So it's from the paravertebral ganglia. And one of them do not secrete catecholamines. That is basically mainly in the neck and at the base of the skull. They don't produce the catecholamines. So phaeochromocytomas, the biochemical tests, these are the most important things for the SE exam as far as we are concerned. So this is initially by the plasma-free metanephrines or urinary fractionated metanephrines. So it depends on the trust. If you're working in the UK, it depends on the trust which will decide in a patient who is suspected to have phaeochromocytoma which test is to be used initially. So in our trust, usually we use the urinary fractionated metanephrines. And for the plasma-free metanephrines, liquid chromatography with mass spectrometry or electrochemical detection, LCED, or LCMS, that is with tandem mass spectrometry, is preferred or is only done over other methods. No other methods are recommended actually. So the LCED or the LCMS methods are the standard recommended methods for the biochemical testing. And both normetanephrine and metanephrine don't elevate together. I mean, they don't rise together. So if they rise, they occur as a false positive. Then another consideration is if normetanephrine or metanephrine I'm sorry, I just made a mistake there. Elevations of both normetanephrine and metanephrine are rare as false positive. That means that it could occur in half of the patients with adrenal phaeochromocytoma. But solitary increases either in normetanephrine or metanephrine more than threefold. They are also rare as false positive. So these should be followed up. I mean, you are not going to look whether the normetanephrine or the metanephrine is elevated alone. In half of the patients, it could be both that could be elevated, or if there is an increase in threefold, more than threefold in normetanephrine or metanephrine, such cases also could be followed up. Borderline positive cases usually result from inappropriate sampling And so repeat sampling in supine position is important. And if results remain equivocal, I'm sorry, I think it's elevated, I've written here, clonidine suppression tests with measurement of plasma non-metanephrine could distinguish true positive from false positive. Now this is very important, the test for the phaeochromocytoma and the paraganglioma. The sensitivity and specificity. As you can see from this chart, the serum metanephrines have got the highest sensitivity as well as the specificity. But you can see that specificity is also high, sensitivity is also high for 24-hour urinary metanephrines. So 24-hour urinary metanephrines could be used as a screening test in most of the trusts in the UK. So they use that instead of the serum metanephrines, which tend to be a bit costly. But if any question on sensitivity or specificity is asked, the most specific and the most sensitive will be obviously serum metanephrines. But 24-hour urinary metanephrines is also a highly sensitive test, but the least specific. So these are the factors which are associated with the false positive 24 urinary catecholamine results. Like, you could see these drugs like paracetamol or amphetamine, cocaine, beta blockers, ephedrine, TCAs, L-DOPA, and foods like which contain pepper or bananas, and nicotine, caffeinated drinks. Also a few conditions like CVA, heart failure, eclampsia, MI. So before you order the 24-hour catecholamine test, we need to look whether the patient is already on these drugs, or whether they have these underlying conditions, or the patient is a current smoker. And coming to imaging, the first choice is CT rather than MRI. So why? It's due to the spatial resolution. So CT gives you an excellent spatial resolution, but there are conditions where you use an MRI. So that's when you have a PPGL with METs, skull base and neck paragangliomas, artifacts, especially in people who have surgical clips, which could produce artifacts on the CT. And then obviously if you have a CT contrast allergy, and also in people who should have less radiation exposure, like children, pregnant women, and also in people with germline mutations. Another imaging modality is I-123 MIBG. So this is this is usually done when I-131 MIBG radiotherapy is planned, or in other conditions like if you have increased risk for metastatic disease, recurrent disease, multifocal disease. And it's a gold standard to confirm phaeochromocytoma or paraganglioma, but it is not usually done except for the indications which I've given. And in non-patients with metastatic PPGL, the preferred imaging modality is PET CT scan. So that should be in mind. So genetic testing now in phaeochromocytoma. So the most important I would underline here is patients with metastatic disease. Usually they have a SDHB mutations. Then you have 6 familial autosomal dominant diseases, which are associated with the phaeochromocytoma. So that should be also kept in mind. These are the neurofibromatosis 1, the MEN2, the von Hippel-Lindau syndrome, the Carney triad, and RCC with SDHB mutation. So a renal cell carcinoma could present with that, and the Carney-Stratsky's syndrome. And germline SDHB mutations it's an important risk factor for malignancy in PPGLs, and it's an important poor prognostic factor. So if you don't have a syndromic or a familial or a metastatic presentation, which are usually, in the indications for a genetic testing in Pheo, if in the absence of that, genetic testing would be suggested in non-syndromic PPGLs or Pheos who have less than 50 years of age, in children, in bilateral, multifocal, or multiple or malignant PPGLs and Pheos. Why? Because of the mutations. The mutations increase in these groups. So there is a decisional algorithm for genetic testing in patients with proven PPGL. I know that it's quite complex, but if you want to get if you want to get more information, you could just read the guideline from the Endocrine Society. And finally, there is a 20 to 25% of PH and PGL to have a familial or genetic origin. Forgive me for the spelling mistakes here. So this is the decision algorithm for the genetic testing. I know it's quite complex. So if you want more information on that, you can read it from that, because this is not this is not needed here for much. Now you have the intra-abdominal and the extra-abdominal paragangliomas, the features, So in men too, when you have the phaeochromocytoma, that's in the adrenal, and the hormone is mainly adrenal, and there is no mets. Okay, in extra-abdominal PGLs, who are associated with the mutations, mainly the B and the D. The B is it's quite a dangerous one, because it produces approximately more than 60% of mets, and it produces both noradrenaline and dopamine. So that's its characteristic. And SDHD mutations are more in head and neck PNGs. So mostly they don't secrete any hormone, but sometimes DA, and the mets are very rare. And finally, if you go to von Hippel-Lindau syndrome, it could be associated with both adrenal and extra-adrenal paragangliomas, which you all know, and mainly the noradrenaline is secreted instead of adrenaline. So the tumor location, the presence of mets, and the types of catecholamine, these are the three factors which are needed to be taken into account when you order a genetic analysis. Finally, again, SDHD mutations, most common with head and neck, SDHB mutations associated with mets, bilateral tumors, and extra-adrenal disease. Management. So the first initial management will be medical. So alpha and beta blockade. Before receiving IV contrast or undergoing any procedure such as venous sampling or surgery, it is imperative that the patient should have alpha blockade. Why? You might all know, because it could precipitate a hypertensive crisis due to unopposed alpha-adrenergic stimulation. So alpha blockade first, followed by the beta blockade. So how do you do that? So we do it by giving phenoxybenzamin. So as soon as the diagnosis is made, so it's per oral. So it is given 10 milligram initially twice daily, and then it could be increased up to 20 milligram 4 times a day. And beta blockade, when do you give beta blockade? Like when you have enough or adequate alpha blockade, you give the beta blockade. So how do you find out that you have got the, enough alpha blockade? So when there is a postural hypertension, I mean, that's quite suggestive of an adequate alpha blockade. And the drug of choice is propranolol. You give it 20 to 80 milligram 8 hourly, 48 to 72 hours starting phenoxybenzamine. It should be commenced in hospital, the beta blockade, and the blood pressure, pulse, and hematocrit. It should be monitored. And the targets are like 130 to 80 or less sitting, and 100 milligram systolic standing. So you can see that it produces a 30 millimeter of BP fall, and the pulse 60 to 70 and 70 to 80 respectively in the sitting and standing positions. So you can see that such a postural drop and a postural tachycardia shows that there is enough adequate alpha blockade. It's also important to check the hematocrit, because there could be an element of hemodilution. So you have to check this HB preoperatively. So surgical, you need to ensure that IV phenoxybenzamine is given 3 days before surgery. I mean, it has to be started 3 days prior to the surgery. Surgery, it's curative in most of the people. Most of the people do achieve normotension at that 75%, and mortality is less than 2%. So, it's a good option, and I think it's the only option to reverse the complications from the Pheo. So the Endocrine Society basically insists that the teams which are going to operate the patient should have enough expertise. Ideally they should be dealing with these surgeries quite a lot, both the anesthetic and the surgical teams. So that's an important aspect. And if the tumor is small and benign, it's laparoscopic. Mostly it's laparoscopic. But there are occasions when you do that as an open surgery, which I'll discuss it later. And during the operation, the anesthetic management should be quite meticulous. There could be hypertension, so which should be managed by phentolamine or nitroprusside or IV nicardipine. And if there are arrhythmias, esmolol or propranolol. And there's a good chance that there will be hypotension. So initially, volume replacement, and then if it doesn't correct the hypotension, inotropic support. So what are the risk factors for hemodynamic instability during surgery? So this is something which is asked in the exam. So these are basically 4. So one which you could always remember is a big tumor, just a large size. And if the pre-op adrenal concentration, non-adrenal concentration is high, and there is a postural drop after the beta blockade, I mean a significant postural drop after beta blockade, such patients should be carefully operated. And if the mean arterial pressure exceeds 100 millimeters of mercury. Follow-up, it should not be performed until 2 weeks postoperatively, because you have the catecholamines in your serum, in the serum of these patients, till 10 days. So it's basically by the 24-hour urinary free catecholamines, but it's 2 weeks after the surgery that you do. So lifelong follow-up for patients who are having mets, or having a malignant tumor, or who are prone to have recurrence. Why you have to do the lifelong follow-up? Because if it is a malignant tumor, the histological specimen won't show you malignancy. Another marker is chromogranin A, but as you see, it could be falsely elevated with PPI, steroids, liver failure, renal failure, and other conditions which I've seen shown. In malignant tumors, you use long-term alpha and beta blockade. And for symptomatic relief, you could use the TKI inhibitor, alpha-methyl paratyrosine. In metastatic disease, you use the high-dose I-123 MIBG. So prior to doing that, you need to scan with the you need to do the I-123 MIBG, so which I've already told you before. And some of the malignant tumors are treated with chemotherapy, including cyclophosphamide, vincrispin, doxorubicin, dacarbazine. These are all for symptomatic relief. Radiotherapy, finally, if you have body mets, which are rare, but it's given as a palliation. And there is some ongoing research on VEGF inhibitors, which is left up to you. So I will just tell you about IMIBG scanning. So IMIBG scan. So it's the compound is a chromaffin seeking analog. So wherever you have the chromaffin cells, it will try to locate that. So it's positive in 60 to 80%. So I mean, it can detect 60 to 80, but it's 100% specific. So it could locate tumors not visualized on MRI with multiple and extra-adrenal tumors and mets. So that's why it's basically used. So the specificity is 100%. The only problem with the MIBG imaging is like you need to switch off the phenoxybens. I mean, if the patient is on the phenoxybens, it could lead to a false negative imaging. So that's quite important. And finally, PET scanning. It is superior to MIBG in localizing metastatic disease. So that is usually, it's a gold standard in metastatic disease. Drugs interfering with MIBG, you can see that in your Oxford handbook. So you got the opioids, cocaine, tramadol, the TCAs, sympathomimetics like ephedrine, pseudoephedrine, phenylpropylamine. I mean the cold medications. Antihypertensives like, again, the beta blockers, labetalol, metoprolol, CCBs and ACIs. I wanted to tell you something about the clonidine suppression test. So this is basically done when you have the the biochemical testing when it is equivocal, or even if in a supine position you cannot do it. So it's basically done in a supine position, and the patient is ideally cannulated for 30 minutes. And then you give 300 micrograms of clonidine orally, and you take catecholamine levels at 0, 120 and 180 minutes. So failure to suppress is suggestive of a tumor, but it could have a false positive rate, but it's quite low in patients with hypertension. So it could be falsely elevated in patients with hypertension, even though it's very, very low. Okay, so when you suspect, or when you want to do the genetic testing, always image the kidneys first, because RCC could be commonly found. A bit more about the SDH. So it has 4 subunits. The succinate dehydrase, as you all know, it's a main component of the Krebs cycle, and it down regulates HIF1 alpha. So the C and the D subunits anchor A and B into the inner mitochondrial membrane. So that's a small description of that. So SDHD, as I've already told, it's a head and neck tumor. So familial carotid body tumors. SDHD mutations are quite common. Germline SDHA mutations are associated with juvenile encephalopathy. And most of the SDHD mutations show maternal imprinting. So there is a potential risk from getting it from the father's side, from the paternal side. So that should be kept in mind too. And if you have a SDHB mutation, it mostly suggests that the phenotype will be a malignant type. It will mostly suggest malignancy. So again, to wrap, the Endocrine Society guidelines, which is the bread and butter for this exam. So if you suspect pheochromocytoma, first you go with the biochemical testing. So it's initially plasma-free metanephrines, or UFCs, or urinary fractionated metanephrines. Liquid chromatography with mass spectrometry or electrochemical detection. Then for measurements of plasma metanephrines, they recommend patient to be in the supine position and use of the reference intervals in the same position. If you have the positive, if the patients are tested positive, then definitely follow. So imaging studies to locate the Pheos and the paragangliomas, if there is biochemical evidence, if there is only biochemical evidence. So CT again. So why? Because of excellent spatial resolution. An MRI in patients with metastatic PPGL, skull base and neck PNG, surgical slips which could cause artifacts, allergy to contrast, and in people who in whom radiation exposure should be limited, and with known germline mutations, recent radiation exposure. So when do you use the I-123 MIBG? So in the metastatic PPGL, when radiotherapy is planned, when there's a large size of the primary tumor to be removed, or extra-adrenal multifocal or recurrent disease. So PET scan, once again, in patients with METs, PET is the preferred imaging modality over the MIBG in known metastatic PPGL. So if the patient is known to have metastatic PPGL, PET is the preferred imaging modality. It's not MIBG, it's PET. So you need to remember that. In non-metastatic PPGL, PET is the preferred imaging modality. So genetic testing is a shared decision making. That means the patient should know what he's being tested for. So as I've already shown you before, there's an algorithm. So it's based on the clinical feature. So it's driven by the clinical features. And people who have suspected germline mutations, who have other features, like features of VHL or NF, and in metastatic disease, because the SDHB mutations could be there, and the pre-test and post-test counseling should be available, and the test should be in accredited laboratories. That's quite important, even though it's ungraded. The evidence is ungraded for that. And again, perioperative medical management. So preoperative blockade to prevent perioperative serious complications. So just before the surgery, you have to start the phenoxybens. Ideally 7 to 14 days have to be given so that the BP and the heart rate normalizes, and include a high sodium diet and fluid intake to reverse catecholamine induced blood volume contraction preoperatively. And immediate post-op, you need to monitor the BP, heart rate, and blood glucose. And on follow-up, like with plasma or urine levels of metanephrines for persistent disease. For metastatic or recurrent disease, lifelong annual biochemical testing. And surgery, when you come with the options for surgery, so the choice for adrenal pheo is minimally invasive lab. But open resection in large tumors or invasive phaeochromocytomas, so that we can completely remove the tumor. Open resection for paragangliomas, that's quite important. So minimally invasive lab for adrenal pheos, whereas open resection for paragangliomas. But in some centers they use lab in small paragangliomas. Finally, about partial adrenalectomy, it's in selected patients with hereditary pheo, and also in people who have undergone a contralateral complete adrenalectomy. So you don't want to, you just want to spare a part of the adrenals, so you don't want to have the patient to go to adrenal failure. So in those cases you just spare some part of the adrenal, so partial adrenalectomy. So thank you, and I know it's my first endeavor, and I know it's not perfect, but I think it will be mostly useful for you. I'll be uploading few other topics on adrenals, so I'm planning to do the adrenals. If you got any queries or any questions, you can always contact me in the email address given below. Thank you.